Pam.
You're
I've
welcome.
had a great pleasure working here. So I am independent in my own practice, but I just sort of make use of True Care and their facilities and the lovely staff. They're incredible, as you guys all know. So I just kind of want this talk to be basically a little overview of certain conditions, and I've kind of made it a little tongue in cheek so it's easy to understand. It's easier to understand in terms of like, what does it mean to you? What does it mean to overall health? And even like the impact that it has on our country, because I sometimes feel that we forget just how important heart health is. I'll touch a little bit about certain conditions and we'll kind of go through that. But my background, as Pam said, is I actually do both. I was trained first as a general cardiologist, which you have to do. Well, originally the training is you do internal medicine, and then you go on and you do a couple more years of general cardiology, and then you do an additional year of interventional cardiology. So I run the whole gamut, but I've basically focused on adult, general, and interventional cardiology, which means everything from general cardiac conditions that you might have, and then all the way to performing stents, pacemakers, or even certain venous procedures that can help. I don't do surgery, so that's the distinction. Those are cardiothoracic surgeons. They're the ones that are doing bypass and stuff like that. But my goal is to make sure that you don't get to that point. So we're trying to do prevention, and if needed, do stents and balloons and angioplasty if you need it, but still prevent you from having to get all the big and heavy stuff, okay? So the way that I'm kind of breaking up my talk is we're going to talk about, first of all, what is heart disease? You know, when we say that, it really means a lot of different things to a lot of different people, you know? So really, it's just a catch-all term. And it can range from talking about arrhythmias to congestive heart failure to coronary artery disease. Heart disease can also represent valve disease. So we have 4 valves in our heart. So any number of things, if we look at the heart, we can talk about different ways, and that itself is heart disease. Why is this such a big deal? Because heart disease is still the #1 cause of death for both men and women, not just in this country, but pretty much throughout the world. So, you know, throughout the world, they're also getting more on the Western diet. So that's why, you know, previously in developing countries, it used to be that infections were the #1 killer. But as their diet patterns changed and we've kind of exported McDonald's and KFCs and Taco Bells and Coca-Cola, they're now seeing more heart disease than they ever have, you know. So it's still a huge factor in our healthcare system. We spend billions and billions, over 300 billion in healthcare dollars. Still the #1 cause of death. Gladly, we're kind of making some improvements along the way, but you have to understand it's not just one thing causing this. There's so many factors that are involved causing heart disease. So we have to sort of like attack it from different fronts. You know, there's a diet front, there's an exercise front, there's a hypertension front. So whatever it is, we have to look at heart disease from different angles and not just say, okay, well, this one thing that we can do can make all the difference, okay? So the types of heart disease, I'm gonna break it down by basically arrhythmias, hypertension, heart failure, coronary artery disease, and then we'll end the talk on talking a little bit about what we can do for prevention and how we can improve our lifestyle to help prevent heart disease, okay? If you look here, heart disease, even though a lot of other diseases get a lot of marketing, I should say, like cancer always gets a lot of marketing, heart disease is still the #1 killer in both men and women. So you can see the graph there. It just shows you the breakdown. Now, COVID briefly last year took over the #1 spot, but you know, thankfully we're kind of getting that under control. So, and we'll also talk about COVID and heart disease. It's not going to be a full talk about that. I previously gave a talk last year about how COVID can affect the heart. And I'll kind of give a little bit of a follow-up on that and let you know what the latest data shows. So we're breaking it down. A is for arrhythmias, B for blood pressure, C for CAD, congestive heart failure, D is diet, E is exercise, and then we'll finish off there. So one of the things to remember, though, even though I'm talking about these as separate conditions, is that many times one of these conditions can cause something else, which can cause something else. So when you finally show up in the doctor's office with a symptom, we got to figure out, we basically got to figure out as detectives what caused what. There's sometimes often a domino effect that occurs. And so, you may have one symptom and we may think it's one thing, but then when we go digging, we may find that it was actually caused by another problem. So I'll give you an example. There's a valve problem called aortic stenosis, which is where one of the valves in the heart doesn't open up. So a valve is basically like a door. So it lets blood out through the heart and out into the rest of the body. And if that door starts to get sticky and jammed, it's not going to open as much, and that can cause a condition called aortic stenosis. Now, if that hadn't been detected or checked or found in time, guess what? It can lead to an arrhythmia called atrial fibrillation. That arrhythmia can also, and aortic stenosis can also lead to a condition called congestive heart failure. So that one condition can now lead to a bunch of different things. And we're trying to figure out, put it in order of what caused what. Because guess what? If you don't go at the source, you're not going to fix all the problems and you're just going to be playing whack-a-mole down there. So a lot of conditions, that's why it's important if you have symptoms, you want to get it checked and just don't brush it off, even if it supposedly gets better. Because if it's getting better, it probably means that your heart's just trying to compensate, but after a while, it's just needs help and then it's going to eventually show up. So if we look at symptoms, symptoms can run the gamut, depending on what kind of problem that we're talking about. Sometimes, they can be associated with certain conditions and other conditions, like the same symptom. So you could have symptoms of palpitations, like a fluttering. You could have chest pain. Chest pain can occur with not only coronary artery disease and blockages, but it can occur with arrhythmias. You can have shortness of breath, which can occur again with a whole host of cardiac and non-cardiac conditions. You have leg swelling, which we call as leg edema, and you can have lightheadedness or dizziness. Sometimes symptoms in men and women differ. We say that women tend to have different symptoms as far as atypical, meaning like if they're having a heart attack, they may not have chest pain. They may just have abdominal pain or indigestion, but it might be a really life-threatening condition. So certain things really span the breadth here. So it's very hard to say this symptom is always this condition and to combine the two like that. So if we're talking about arrhythmias, I don't know if you guys can see that. That feeling when you meet someone and your heart skips a beat? That's an arrhythmia. Yeah, you can die from that. So little tongue in cheek there. Most arrhythmias, I will say, are actually not dangerous. There are a few that are deadly, but majority of the time, I would say most arrhythmias that we see is usually not dangerous. And we'll kind of talk about the main ones that we deal with commonly. The usual symptoms that we typically see is palpitations. And honestly, we see a lot of that in cardiology clinic. People come in all the time saying, I feel like my heart is racing. I feel it's irregular. Sometimes they say, well, when I'm laying down to rest at night, I feel my heart beating or pounding. Can occur with shortness of breath and occur with chest pain. So we have a couple of things. So an arrhythmia is basically an abnormal rhythm of the heart. So we have to find some tests that look at the rhythm. So the first one is going to be the EKG, looking at exactly what is your rhythm of the heart doing. Then, we use things called Holter and event monitors. And what those do is help us detect arrhythmias when they're occurring infrequently. If you show up at our office and you're not having palpitations, you very well may not be having an arrhythmia at that moment. But guess what? When you get home, that's when you feel it, right? You're never going to have it in the doctor's office, but you're going to get it when you're at home or resting or whatever. So we have monitors that you can place on there, basically like a portable EKG monitor. that you can walk around with and help detect this thing. The iWatch, the new iWatch, also has a little arrhythmia detection thing. So very similar technology, but we've been using it for decades. An echocardiogram we would also use basically to see if this arrhythmia is causing any problems. Like I said, is the arrhythmia then caused a problem with your heart function, or is it because you had a valve function? So the way that we kind of break it up is look to see where in the heart this arrhythmia is coming in and what kind of arrhythmia. You know, we usually label the most common ones called SVT, and I'll talk a little bit about that. But the ones that mostly I want to focus on is something called atrial fibrillation. And ventricular arrhythmias, I'm really not going to talk much about, but those are the ones that are associated with heart attacks. They're extremely severe. They're life-threatening. People need to be shocked. You know, this is when you use a defibrillator to shock them back into normal rhythm. So they run the gamut of being mild, ones called SVTs, all the way to severe deadly arrhythmias, okay? So a normal rhythm in our heart is something we call normal sinus rhythm. And if you've seen the EKG, this is what a classic normal EKG. And what we're looking at is all these different little identifications of that electrical wave, because every single wave point here is from a different part of the heart and a different part of the cardiac cycle. So we use this to interpret, you know, try to figure out which part of the heart is actually affected. So EKGs are extremely, extremely valuable in many times just to figure out where the problem is. And the way that our heart works electrically is that within the wall and within the muscles of the heart, there's little electrical pathways where that electrical activity initiates and then kind of comes down. So it starts in this thing called the sinoatrial node, SA node, travels down the AV node, down the remaining chambers of the heart. And so, you know, if some of you may have heard the term bundle branch block or left bundle, it just means that certain pathways have a blockage in it, quote unquote, or basically a short circuited, since we're talking about an electrical system. So think of your heart, it's got plumbing in there, which is the vessels, it's got electrical problems, it's got, you know, electrical circuits. So when we have different short circuits, they can show up as different arrhythmias. This is what a nice normal sinus rhythm looks like, a nice waveform on our EKG. And it's just kind of showing here the anatomy. So specific points of the heart, if they're affected, they can cause a problem in the rhythm problem. When we have problems in conduction, we call them conduction problems. They're still arrhythmias, but then we have all these different types of conduction problems depending on which part of the heart they come from. So I'm not going to get into that. But basically, the EKG was invented back in the early 1920s by Einthoven. And you can see this crazy contraption where he had to put his arms in a salt water bath, his legs in there, and be hooked up to all kinds of electricity. More than once, this poor guy electrocuted himself. But despite all that, he was able to persevere and got a Nobel Prize for inventing and discovering the electrocardiogram of the heart. This is one of the most common tests that we do. Luckily, like it's very simplified today. So this is what we have, something called a 12-lead EKG, which basically you have the leads going all different places around the heart. And we're trying to look at the heart from different angles. So basically we're taking electrical pictures of your heart from different angles. So what can you tell from an EKG? I apologize, some of this is cutting over the slide there. But arrhythmias, as I said, people that are having heart attacks, you can tell what kind of heart attack it is. If it's acute, meaning like it's sudden, or if it's old. We can also tell if blood pressure is affecting the heart, and a myriad of other things. So just interestingly enough, I just put this picture in here, and this one is a very dramatic EKG. And if an ER doctor saw this, he would be on the phone with a cardiologist right away, because what we're looking at is a very sudden and dangerous form of a heart attack. In fact, we call these things, if you look at this segment right here in the middle here, we call those tombstoning. because they remind us of a tombstone. So if you don't take this person to the cath lab and do something about that blockage, this is why we say that, okay? So certain things like that, you know, our EKGs are very helpful. One of the arrhythmias, remember if we talk, I said is something called SVT. And in SVT, the name for the acronym is supraventricular tachycardia. So it just identifies where this fast heart rate or tachycardia is coming from. And it just means towards the top of the heart. The arrhythmias at the bottom of the heart are usually more dangerous. The ones from the top of the heart, more benign, like meaning they're more common as well. So an SVT is extremely common. I would say over 90% of people who have some kind of arrhythmia usually have some kind of an SVT, okay? It's basically an abnormally fast heart rate, and there's different kinds of SVT. We have all these fancy names depending on what they do, what kind of circuit they follow inside the heart. Many of them just you watch. I would tell people, listen, if it's not bothering you all that much, it's more of a nuisance in your life, but it's really not going to do anything to your heart. It's not destroying your heart. It's not going to give you a heart attack. You know, if it's otherwise just something you feel, leave it alone. We can give you medications to treat it, but there's actually maneuvers I would teach you, which are certain things called vagal maneuvers. And there's 3 vagal maneuvers. And anyone can get SVTs at any time in their life, okay? So, but what you can do to terminate them is, what the first thing is cough really abruptly and hard. 2 is like strain or bear down, like you're contracting. And the third thing is to find your carotid artery and just rub it vigorously, okay? You can do one of those or a combination of those. And sometimes that's enough just to stop one of those SVTs, okay? It may not work with all of them, but in many times they will, okay? So SVTs occur from the top portion. So we have 4 chambers in the heart. There's left and right atria. And so what we're looking at, this is actually the left side, even though it's on the right, you have to look at it as if your heart is in your chest. This is the left side. This is the left ventricle, right atrium. So the SVTs originate somewhere up here in these chambers. When they're down below in the ventricular chambers, we call them ventricular arrhythmias. Again, those tend to possibly be more dangerous, but thankfully, most of the time they're originating from the top. But you know, we don't know what people have, right? So when you come in saying I have palpitations, that doesn't tell me enough, because it could be any SVT, it could be ventricular tachycardia. We got to figure out what kind of rhythm problem it is, because guess what? They're all treated a little bit differently. Some of them you just watch. Others, I would say, listen, you know, there's procedures out there called ablations that can be done to get rid of it so you don't have it. Some have consequences for not treating. So there's different ways. So the first thing is diagnosis. You want to figure out what is the thing. And this is one of those little patches that we have. This is newer technology. Not a lot of clinics or offices actually carry this. In my old practice, we didn't have this. We had the bulky, like, little recorders that people would have to put on. But right now, the company that we use actually has this little recorder where you can wear it on your chest for up to 14 days. You press a little button on there if you feel anything, and it takes a recording. So here's a sample report on someone. And this is the kind of reports that I look at and review. And this person, they had abnormal rhythm here, which identified as ventricular tachycardia. Here, the heart essentially stopped for a whole 3 seconds. There's absolutely no heartbeat there. And here is another arrhythmia called atrial fibrillation that shows up, okay? And for comparison, here's just a small segment of a normal heart rhythm that occurs. So we can see all sorts of things with these things, and we can, and if we, as long as you have a rhythm when you're wearing this patch, I'll be able to tell you exactly what we found and what is it, and if it's something to worry. Here's examples of an SVT. Like, this is a really fast rate. It's about 150, 160 beats a minute. So each one is a heartbeat. Here's one where it actually breaks and goes back into a normal rhythm. Okay, so just examples of that. One of the most common ones, and actually more significant one, is called atrial fibrillation, a term that very many people are probably familiar, or at least heard of. Over 2.5 million people have it. And as you get older, it becomes more and more common. So your lifetime risk is actually a 25% chance over your lifetime of actually getting it. Okay. There's probably more people that really, and I know this for a fact. I mean, a lot of people are not diagnosed because sometimes they just don't have any symptoms. And so they don't get caught with atrial fibrillation until someone happens to, check their pulse or do an EKG. So symptoms, again, very similar to any of the SVTs. So it can be nothing. It can be palpitations. Some people just say, hey, listen, I'm not able to walk as far as I could. I used to be able to take the stairs, and now I find that I'm very short of breath. And what's going on is that your heart is beating irregularly. So here's a nice normal heartbeat. So, when your heart beats, it beats from the first the top chambers, then the bottom. And it beats in electrical synchrony. So, there's an electrical impulse that tells that muscle to beat. Now, when it's like boom, 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 that's nice, normal rhythm. But with atrial fibrillation, you have something that could be like boom, 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 boom. And when you do that, your heart muscle is like now quivering at times, and it's not pumping efficiently as if it was in a normal rhythm. So it can beat too quickly, too slowly. It can cause people to feel fatigued because they're not getting the blood that they need in their body and their muscles as they should. And normally atrial fibrillation comes from these top chambers. Again, it's a type of a supraventricular, so coming above the ventricle, but it actually comes in certain areas called the pulmonary veins, where it's classically been shown to originate from. And this is just an example of a normal heart rhythm, and two examples of how irregular each beat is on the atrial fibrillation. Why is it important? Because AFib can cause strokes. That irregular pumping of the heart, what happens to blood when it's not circulating or moving around? It clumps up, right? So that little irregularity is enough to cause tiny little clots, which can have a devastating consequence if that clot breaks free and goes up into your brain and causes a stroke. So unfortunately, many people are often diagnosed with atrial fibrillation after they have had a stroke. So if they've come in too late, they're bound to have a stroke. So where does it come from? So there's a little thing called an appendage inside the heart. This is the left atrium. So right here, we have something called an auricle, which is basically Latin for ear. So you have a little ear, and in that ear you can see a little clot here. This is exactly from atrial fibrillation, where this part of the heart has not been moving all that well. Blood stagnated and caused a little clot. That clot can just break loose, and the next place it usually travels is to the brain. Now, it can go to different places in the body, but it's mostly significant. So what do? We use blood thinners, and I tell people like this is extremely important. Not everyone needs a blood thinner, but there's risk factors. Studies have shown if you have heart failure, high blood pressure, if you're older than 75, if you have diabetes, if you've had a stroke, if you have history of other vascular problems, you get points, depending on which category you fall in. Women are actually at a higher risk for strokes than men are. And we have certain, blood thinners. If you're very low risk or really have none of these, I would say just use aspirin. Aspirin's good enough. However, if you have at least one of these or at least two of these, then you definitely want to be in a stronger blood thinner. My personal one favorite is Eliquis. It's got great data out there. It's actually stronger than a lot of the other ones, but actually has less bleeding. So I tend to use that, but we have certain other ones out there. The older ones is warfarin and Coumadin. We used to use it commonly. They're generic. It's a great medication, but it's a pain in the butt to take. There's all sorts of dietary restrictions with warfarin. You got to monitor continuously your INR. These other blood thinners are so much easier to take, and in some ways so much safer to take because you just take it like any other pill. So ways to treat atrial fibrillation. So we have a cardioversion, which I'll talk about in a second. Ablation. We can use medications to try to get your heart rate. So if we just found out that you have AFib and you've not been known to have it before, we want to try to get you back into normal rhythm. We don't want to try to leave you in AFib. A lot of people can stay in AFib and do okay, but for your heart and for your longevity, it's better that we treat you and get you back into sinus rhythm. Okay. If it's been going on for years and years, then it may be a moot point trying to convert it, because by that time it may have settled into your heart and become more permanent. So at that time, we'd say, okay, we just want to make sure the heart rate's okay. We'll just put you on something as a blood thinner, but otherwise we'll just leave it alone. These are some of the medications we would probably use to try to treat the atrial fibrillation. Now, the cardioversion is the quickest way. What we do is we would take you to the hospital, use an anesthesiologist to put you to sleep, put these pads on there, and look at this guy, he's so happy. He's about to get cardioverted. We put you to sleep, we press a little button and zap your heart. And many times I've seen so many patients quickly convert from atrial fibrillation back into sinus rhythm. They're awake, let the anesthesia wear off, and then they're back home. And that's one of the best ways, actually, honestly, to convert them. Now, this is not going to work the longer you're in atrial fibrillation. If you have AFib for years and years and years, it's already settled in. It's kind of made its home in the heart. So, but it's always worth a try, I think, to at least try to get your heart rate back into a normal rhythm, the way that it was meant to be, you know. Ablation is a different technique. This is not something I do. We have other cardiologists, specialists called electrophysiologists, and they're the electricians of the heart. So what they do is they take these little catheters, they take you to the cardiac catheterization lab, and basically they map out different parts of the heart where the arrhythmia is originating from. And they basically burn that little bit of tissue. So you can see here, they put all these little catheters, figure out where exactly inside that heart. And you're talking about millimeters to centimeters worth of differences that, you know, they're not looking, they're not cutting open into your heart. Everything is done through the arteries and the veins of from your extremities. So that's atrial fibrillation. Let's move on to blood pressure. B is for blood pressure or hypertension. So basically, blood pressure above 140/90 is considered hypertension. If you're diabetic, your goal should actually be under 120/80. So but the general population, we just use this as a goal. And it's severe if it's over 180/120. And we know a whole host of different things: smoking, diabetes, not taking care of yourself, the wrong diet, certain tumors. There's a genetic component, you know, if your parents had it, they may pass it on to you. Symptoms. So people can show up depending on how high the blood pressure is, with headaches, fatigue, dizziness. But honestly, the most common symptom is nothing. We call this the silent killer, because you wouldn't even know you have it unless you're getting your blood pressure checked. But why is it a killer? Because it can cause all these other conditions. You know, it can cause vision loss, cause your kidneys to fail. It can cause stroke, cause dementia. It can cause heart attacks, congestive heart failure. There's a whole host of things. And hypertension is so common that almost 50% of Americans have it. And you can see the prevalence here throughout the US. The darker the red, you know, it's almost approaching 40–50% of the population in some of these states down there. But, you know, I will say they have really good food down there too. So there may be some correlation. So men, a little bit more than women, and it's more prevalent in the Black and Hispanic communities. Again, here's just showing you a whole host of hypertension effects. But on the heart, it can cause something called hypertensive heart disease. Now remember, the heart is a muscle. And if it's pumping against hypertension, against all this high blood pressure, it's like any muscle. You go work out at the gym, the muscle becomes bigger and stronger. That sounds great. So the heart will actually get thicker. The muscles of the heart will actually get thicker. Well, that doesn't sound like a bad thing. Well, what happens is it's going to tire out. If it's continuously having to pump against that high blood pressure, if it has to work harder than it needs to, that muscle is going to fail. And guess what's going to happen? You're going to get something called congestive heart failure. You're going to start seeing fluid in the legs because it's affecting the kidneys. You're going to see fluid in your lungs, and that's going to cause you to feel short of breath. Okay. So this is why we don't want the heart to work harder than it has to. This is one of my pet peeves because, almost every clinic visit, I always get someone that says, my blood pressure got better, so I stopped taking my blood pressure medication. So I want people to understand that your blood pressure got better. So do not stop taking your blood pressure medication, because that is exactly why it got better. And that's easy to see because by the time they show up, having stopped their medication, their blood pressure has skyrocketed again. And that is, in fact, is even more dangerous because what can happen is you can get a rebound in your blood pressure. So whereas if your blood pressure is okay and then you stop your medications, everything just sort of rebounds. Your blood pressure can skyrocket and you can actually get a stroke or a heart attack just from stopping your medication suddenly. Okay. So please do not stop taking your blood pressure medication. And I always tell my patients, actually, unless told to do so, always take your medications on the morning of the visit. So especially if you come see a cardiologist, if you come see me, I want to see what your blood pressure is doing on your medications, because that's the only way I'll know if it's working or not. So again, using our handy little ABCD monikers, we have all these different kinds of different medications that fall into different categories. And all these medications have been studied on the heart and their effect. Some of them actually help you live longer. Some actually help reduce the incidence of heart attacks. So these medications, ACE inhibitors, ARBs, they're all classes of medications. And within those classes, these are the meds that we listed: amlodipine, metoprolol, hydralazine, lisinopril. We have diuretics. How else can you manage hypertension? We, obviously restricting the salt and exercise. These are all things you can do to help manage your blood pressure. Salt is always a confusing issue. We don't want to have, ideally for most adults, 2,300 milligrams a day. For people with hypertension, it's down to 1,500 milligrams per day. Okay. That's not very much when you think about all the processed foods that are out there. This is obviously not just you shaking it into a pan while you're cooking, but we have to think about all the processed foods and the sodium contents that are in there, because one Big Mac can get you there real fast and in a real hurry. Okay. So just to show you like what 2,300 milligrams looks like, it's basically a teaspoon, and half a teaspoon is where you should be for heart healthy stuff, right? And I'm talking about in an entire day among all the foods that you eat. So the question is always like, whoa, what about sea salt? What about those kinds of salt? Like, yada, yada. It doesn't matter. They're still a salt derivative. They still work the same way as salt in your body, okay? So my recommendation is switch to spices, switch to herbs. There's a lot of these herbs out there, which, frankly, taste good, taste better, and you're not going to notice the change, okay? Let's move on to coronary disease. And by the way, I do want to save some questions at the end. So just write it down. You can write a chat to Pam there and she'll compile them and then present it to me. Coronary disease is what we talk about when we're talking about blockages. It is the leading cause of death in both men and women in this country. So it basically happens. So your heart has arteries, blood vessels around itself, like supplying blood to its own self. So your heart actually pumps blood to itself as well as the rest of your body. Now, if you start to have cholesterol deposits and fat deposits inside, you're gonna kind of narrow those plumbing and those pipes by filling it up with crud instead of not having nice blood flowing down there. So you can see in a cross section here what a nice clean artery would look like and what something with plaque would look like, and it just shows you how much volume you're losing over time. Why does this matter? Because at rest, you may not notice it, but when you're working out or exercising or just taking a walk or lifting something heavy, your heart starts to beat faster because your body needs more blood. But if it starts to get less blood when it actually needs more, you can feel symptoms of chest pain and angina is what we call it. So symptoms can be chest pain, usually over your heart, left-sided. It can, now in women, it can be very atypical. It can be in the arms, it can be in the neck, it can be in the jaw, head, into the back, into the shoulders. It can cause pain in the stomach. If it's severe, it can cause nausea, vomiting, sweats, chills. So any combination, again, no symptoms. Sometimes people have silent heart attacks and we diagnose it 10 years later. Like, hey, you've had a silent heart attack. Oh, I didn't realize that. Well, that's, so unfortunately it can occur like that too. The tests that we use are EKGs. Showed you an example before of a heart attack. But what we want to do is to see what happens to your heart under stress. What happens when it's racing faster? Are you getting the blood that we need? And that's why we do stress tests. We have walking treadmill stress tests. And for those that can't walk, we have a chemical nuclear stress test. Now you can do it in different combinations. You can do a walking nuclear stress test or whatnot, or we can use ultrasound in the walking. So different ways of doing stress tests. And finally, the most definitive way is a coronary angiogram, where we actually look inside the vessels and see exactly which one is blocked or where the blockage is. Stress tests and EKGs, they're not 100%. We're not looking inside the heart, but they can give you a really good clue as to whether the pain that you're having or symptoms is related to the heart or not. So each of these have their different places. But this is the most common one here at Pacific Heart. Right here at TrueCare, we're commonly doing stress echocardiograms. Basically, we take an ultrasound of your heart, take baseline pictures, we take a baseline EKG, then we have you walk on the treadmill, and we try to get your heart rate up to a certain target and try to keep you going. And then we take you off there, then we do a repeat ultrasound and EKG, and we're trying to see if there's any differences before and after exercise. Is your heart getting as much blood as it needs? There's one of my lovely patients on there. So what happens, and this is supposed to say if a stress test is abnormal. So these are examples of abnormalities, from the EKG. This is nuclear imaging where it shows up. And then this is the echocardiographic imaging of abnormalities. So let's say, your stress test comes back abnormal, you're having classic symptoms. Our next step is, this is where we would take you to, which is the cath lab, also known as an angiogram or heart catheterization. So basically we take you to this room. Most people just stay awake. This is not heart surgery, but it is an invasive procedure. But we would either go through the artery in the groin, but I like to usually do it through the radial artery, which is a little bit more advanced, but it's actually more comfortable for patients instead of their groin. But we take a little catheter and we run it into the coronary arteries. We inject dye into the arteries, which shows up under X-ray. So it's not a camera, but we are taking pictures of your heart. And here's what it looks like. Here's me. I like to point a lot in the cath lab when I'm there. But as you can see, I have a technician with me that helps me out during this procedure. He's giving me the wires, balloons, flushing the catheters, while I'm actually manipulating the wires and the guiding catheters into there. But this is sort of what we look at. These are the kind of images, and hopefully that's playing for you guys. But these are your actual coronary arteries. Now you can't see the heart, but they're actually encircling the heart. Okay, so your heart shadow is right around here. And these are the vessels around the heart. These are the arteries on the left side of the heart, and the section on the right. This shows an artery on the right side. Most people have 3 major arteries. We can have little variations, but we're looking in all of those to see if there's a blockage. And here's an example of a blockage on the left side in the left coronary artery. And you can see here, this is the dye filling in under X-ray, but you see how this is pinched in there. And so that's a stenosis. I would call this probably 80–90% stenosis, right? When we open that blockage up, we put something called a stent to open up that passageway. And now you can see that stenosis, it's good as new. You can't even see it now. And this would probably be done in the same setting. So a stent is basically like a metal tube or a mesh. It comes really crimped down, but we put it on a balloon. And when we're right above the blockage, we inflate that balloon and that stent just expands into place right where that blockage is. And we sort of leave it in that vessel so that blood can, so here's an example of that stent being deployed across that blockage there. And what you're left is with a nice passageway for that blood to go through. This is a case that I did just on Monday. You see this gentleman here. His was in a very critical area. It's really at the beginning of the vessel. And this was a huge vessel. He was very lucky because had this closed down, for certain, he would have had a huge heart attack, possibly would not have even made it to the cath lab. He probably would have died on the spot. But I was able to get a stent in here, and you see a nice result where that vessel, and I apologize, I didn't get the entire picture of the coronary anatomy, but it was a super long vessel and it fed a lot of branches. So it was feeding almost 60% of his heart with just that, with that vessel. So here's an example of, once the stent has been deployed, the blood can now go through that passageway, and the blockage has just kind of been squished to the sides of the wall. Sometimes we find clots in there, and we can see a lot of clots, and we use these things called thrombectomy devices. Basically, it's a fancy overpriced tube that we have to stick in there and basically suck out clot. We use a vacuum on a syringe to suck out the clot. And I kind of want to show you, this is from another case of a sudden heart attack someone had where I sucked out clot. And so you are what you eat. So just be thoughtful of that. It could end up in your coronary arteries. So here's another example from last week. I had a lady who has, if you remember the normal pictures, you can look, she's got multiple blockages. She's got one right here. And then here, nothing else. There should be, the rest of the vessel should have continued. There's no vessels over here. There's high blockages. She's basically living off of one vessel for her entire heart. I was actually kind of shocked seeing that because she was known to have this a couple of years ago, and she was recommended to have bypass surgery to bypass all these blockages. But she refused, but she did okay. And that's kind of a testament to her heart and how the heart can heal, because it can actually provide its own bypasses to try to get the blood to the parts that are not getting. Now, it's not as good as having, clean arteries, but it's better than nothing. Her heart was trying to create new vessels, and you can see all these tiny little things out here, which normally we wouldn't see if she had normal vessels. Common questions is, how long is the procedure? Typically, if we're going in there to take a look to see if you really do have blockages, that portion of it, 10, 15 minutes, my portion, the whole procedure of getting you in the room, getting prepped and draped. So totally maybe 45 minutes, less than an hour to do it. If we do find a blockage, it'll take longer, maybe another 20, 30 minutes, depending on how complex it is. It can be hours, but typically, I would say most commonly within an hour. How fast can you return to your lifestyle? So hopefully you're not going back to the same lifestyle that brought you to the lab. But within, typically if we did the procedure and everything looked okay, we'd have you out the same afternoon. You would drive 48 hours later. You can take a shower that night. You can start walking. You can start exercising within a day or two. So there's really not too many limitations. This is not bypass surgery where, for a month or 2 months, you're recovering and you're not allowed to drive and things like that. Most people are awake. I like to play music in the lab. I always ask them, what kind of music they want to hear. And, we play that for them. Some people fall asleep. They are given sedation. So different things. And is it painful? People always ask me that. I say, don't worry about me. I will be completely pain-free. So the only part that it may sting a little bit is we're getting access in your skin. So it's basically like getting an IV. It'll sting there, but we put lidocaine in there to try to numb that pain. But everything else inside your body, you really don't feel anything. You're not going to feel anything. You're not going to feel the catheter inside you. Okay. So it's truly a remarkable technology that we have and available. So here's a quick little pop quiz. Okay. Which disease below would be the worst to have? Right. So is it breast cancer, prostate cancer, bowel cancer, bladder cancer, heart attack, or heart failure? Someone said number 5. Got to vote for 5. Oh, 6. Yeah. Oh, she's not falling for the trick. The answer is indeed heart failure. And I want to kind of show this, and heart failure never gets that kind of negative press that, say, breast cancer does or other kinds of cancers. But heart failure is actually more malignant, meaning that it's more deadlier than a lot of other cancers, okay? If you have congestive heart failure, you have a 50% chance of being alive in 5 years, okay? So just let that sink in. If you have congestive heart failure, you have a 1 in 2 chance of being alive in 5 years. And this is what these curves, these are basically survival curves, you know. You survive if you're up here. The higher up you are, obviously people die over time. So no one's at 100% forever. But people with breast cancer tend to live longer. And this is 60 months. So looking at 5 years, right? The only cancer that's usually worse, I mean, there's several others, but lung cancer is usually much, much worse than all the other cancers. So you definitely don't want lung cancer. But heart failure is not far behind. So like half the people that started out with heart failure at month 0, half of them are dead by 2.5 years. Okay, that's how deadly heart failure can be, but we just don't think of it in terms. And MI is a heart attack. Most people nowadays are actually living better because they get in because of the awareness of heart attacks, right? You have chest pain, call 911. Okay, get into the ER. You get your EKG. If it looks abnormal, you're rushed to that cath lab and you have a stent placed within 90 minutes. In fact, that's become a standard across the world. We call it a door to balloon time. If you show up with a heart attack in an ER, you will have finished your cardiac catheterization and had a stent placed within 90 minutes. And that has been shown to save lives. And that's why, you know, MI is not as deadly as it used to be before. But heart failure is a whole different animal. So moving on, C is for congestive heart failure, but really it's heart failure can occur with congestion or without. So basically, the way to look at it is heart failure is basically the heart's not pumping enough blood to meet the demand of your body. So we have 2 kinds of heart failure where we basically say systolic, which is the classic where your heart's not pumping. So if your heart's pumping really strong, it pumps weaker. So we call that systolic. Or diastolic, where it pumps okay, but it's not relaxing. Your heart's not relaxing. It's too stiff to relax. And both of those can cause heart failure and heart symptoms. You know, like I said, 50% within 5 years are dead. 650,000 people are diagnosed every year. Your risk of having heart failure over your lifetime is about 20%. It's a huge burden, $40 billion annually on the healthcare system, and over 1 million hospitalizations a year. So it's one of the most frequent hospitalizations, right up there next to pneumonia, as far as that goes. And a lot of times, we don't know if it's pneumonia or heart failure because they kind of coexist and mimic each other. So a lot of times, you know, people are treated for both when they come in because they have similar symptoms of both. What are the causes? The number 1 cause is what we just talked about, which is coronary artery disease. If you imagine if you have a heart attack, part of your heart dies, well, then you've developed heart failure in that thing. Other conditions include high blood pressure, valve problems, something called hypertrophic cardiomyopathy. And here's a whole host of other things. You know, in certain countries, we have parasitic diseases, Chagas, HIV can cause it, thyroid disorders. If you've been pregnant, pregnant females can develop a type of heart failure. Alcohol. The biggest cause, again, like I said, almost 70% is from coronary artery disease. And then there's also a segment called idiopathic cardiomyopathy. So what does idiopathic means? Idiopathic means we don't know. In other words, your doctor is an idiot, and it's really quite pathetic. So we just don't know sometimes. There's reasons why people develop heart failure. You go through all of these screening, and this is the pathway. You got to look at this, right? We have to test for this, and the ways that we test for it is what are our tools? EKG, we can do lab work, we can do an echocardiogram, we can do stress test, check your blood pressure, you know, is it any of these other conditions? Have you traveled somewhere recently, you know? I've seen wild cases, people going to South America, getting bit by a bug, coming back, developing heart failure, right? And that's how you think about all these parasitic and rare stuff that we would never see. But basically, it's a growing problem. You know, as people live longer, they're more likely to get a heart problem. So there will be an increase in how many people will have heart failure over the next coming decade. But these are all risk factors: having atrial fibrillation, diabetic, or being obese. So a sleep disordered breathing is like sleep apnea. Sleep apnea is something that I always look for in patients because it's often overlooked. If you have sleep apnea, guess what? It can cause atrial arrhythmias. It can cause atrial fibrillation. It can also lead to heart failure. So I always try to keep an eye out for people that they look like they might have sleep apnea, and they say, listen, you need to get treated. You need a CPAP machine, and you need to use it to prevent these things. Hypertension, sedentary lifestyle, CAD. Little tongue in cheek, I'm not sure if you guys can see that there. Time is money. So let's go back to, I was talking about the two kinds of heart failure. There's systolic, where there's the failure of the pump. So it's also a newer term that we like to use is reduced ejection fraction. And what is an ejection fraction? It's how strong your heart pumps. There's one thing I could ask you guys to take away from this talk is to find out what your ejection fraction is, okay? And that's how strong your heart pump is, because that is extremely valuable in telling you, like, basically how well you're gonna live, all right? For the heart, an EF is how strong your heart pump is, okay? So know your EF. It's not hard to get. We get it from an echocardiogram, essentially. But it's basically the amount of blood that your heart pumps out with every squeeze of that muscle, okay? So if you can imagine, if your heart function is low versus normal, and a normal is basically anything above 50%. So your heart will never pump out 100% of the blood that's in there. It'll pump out about 50 to 70%, okay? But that's normal. But as it gets down and down, what happens is you're going to start going into congestive heart failure. You're going to get winded easier. And people with lower heart function tend not to live as long. So that's why it's important. Heart failure causes your heart to get bigger and larger. It causes blood to backflow into the lungs. It will backflow into your legs. You get leg swelling. You get short of breath, okay? It causes your heart to appear larger and get bigger and basically soggier, you know, is a way to think of it. We can treat heart failure with all these different medications. Now, some of these same medications we use for different cardiac conditions. They do different things, but they can be used for different conditions. So I always try to find ways to reduce the medication burden by looking at what medications can help with whatever conditions, right? If you have an arrhythmia plus heart failure, let's use one medication that can then attack both problems at once. But, you know, I don't like to use meds if we don't have to, but if we have to, that's where we stand. There's devices called biventricular devices that can help synchronize the heart function and make it stronger. I said no cigs. Cigarette smoking is just adding oil on fire, okay? We use diuretics. We talked about low salt. You know, in severe advanced cases of heart failures, people with severe cases, they're at more risk to have ventricular arrhythmias. So we need to watch out, put that in there. Exercise, watching fluid intake. Moving on real quick, COVID. terrible thing that's happened for all of us. But if you're a survivor, if you've been lucky enough to survive, some people have some cough, shortness of breath, but it can also affect, we're finding out that it can cause inflammation of the heart, which can eventually lead to heart failure. So I encourage people, if they're having any symptoms, come in, get checked, get an ultrasound, just make sure your heart is strong, pumping normal, that COVID hasn't caused any problems. Nearly a quarter of the people that died really died from heart-related problems because of COVID. So there is a connection there. D is for diet. I'm not going to dwell on this so much, but it feels like every time there's a new recommendation on what we should be eating. So honestly, it's more confusing than anything. So really, the only diet that's been shown to help with the heart is the Mediterranean diet. Okay, this is the only diet that has been shown to reduce your chances of heart attack and stroke. All the other diets are just really fad diets. Unless they've been investigated, you cannot say that they're any better for you. And this basically is using good fats, which is unsaturated fats, and avoiding the trans fat, which is basically found in processed foods. You can snack on walnuts or almonds. Use olive oil and for cooking. Okay, replace meat with fish, and fruit for dessert, and then wine in moderation. So, where was that? When I say wine in moderation, I certainly don't mean something like this. Carbs, there's huge war on carbs right now, but not all carbs are bad. There's three main types, basically sugars, starches, and fibers is what I meant to say there. But simple versus complex. You want to get complex carbohydrates, not simple. The simple ones are the ones that are added sugars, corn syrup, fructose. They add it to candies and sodas and pastries. Your body will absorb that really quick. Your sugar will spike and then crash, leaving you craving for more, right? This is why we say use complex carbohydrates, ones that have a lot of fiber in them, because they take longer to digest. They don't cause that spike in glucose. They're actually good for your gut. So these are the ones found in whole grains and quinoa, rice, oats, even potatoes and sweet potatoes, fruits and vegetables. Exercise, I know we're almost out of time here. What fits your schedule? 1 hour a day or being dead 24 hours a day? And really, exercise can improve that ejection fraction. All it takes sometimes is just walking 20 to 30 minutes, 3 to 4 times a week. And when you do that, I don't want just a small little sedentary walk. If you can, take some weights with you and do that little power walk, okay? That is going to improve and strengthen yourself. People talk about 10,000 steps. Do we need to take 10,000 steps? And we've looked at studies and we've actually shown that you get a benefit. This is mortality. So the lower it is, the worse you're off. But it reduces your mortality. So what that means is that really you only need to take about 6,500 to 7,000 steps a day. Beyond that, you're not really getting much more of a benefit. So you can do 10,000. It's better for you. Don't get me wrong. But if you can at least hit 7,000 steps in a day, you're already doing good for your heart. So I always tell people, try to get something that you can monitor that, pedometer or those Fitbits or whatever, And it's hard. I get it. I understand a lot of people are busy, but instead of worrying about losing weight or worrying about this, that, I say focus on the discipline, set a habit and stick to that discipline, and your results will follow from that, okay? So in conclusion, here's a bunch of medical students that I taught recently. Actually, this was pre-pandemic, but we did a pig heart dissection where one company sponsored, brought in all these pig hearts, and we carefully dissected it. And it's very nice to show these students and residents because, we often look at the heart by an EKG or an ultrasound, but we never actually tend to look at it. They're not surgeons, so they never really look at the heart. So it was great. And I took one home to my little boy. Here he is at 5, but he's 6 now. But I took a pig home after that, and I showed him all the structures. And secretly, I'm hoping he'll become a cardiologist or at least a doctor. And he's like, he was so game. He was so cool with everything. I was like, oh, how'd you like it? And he's like, yuck. So we'll see what happens. But ultimately, take care of your heart. It's the only one you got. Cheesy pickup lines from cardiologists. But if you want to find me, you can find me on Instagram under Dr. Krishnan, MD. I'm also on Facebook. If you have the Peloton, find me on there. Give me a high five. We'll work out together. And you can find me here at our office at Pacific Heart and Vascular, which is associated with TrueCare. So I put both numbers on there. My website, gopacificheart.com. I'll post the link to this video, but I also have other videos about heart failure and heart disease and procedures and whatnot. So a little bit more information is on there as well. So very good. So thank you guys for your time. Appreciate it.
Great job. Great job, Dr. Krishnan. Thank you so much. So we will go through some of the questions that we have here on the chat, in the chat room. I will start with the first one. Can you reverse stenosis?
Yeah, absolutely. So by doing those things, taking the right medications, doing the right diet, and doing exercise, stenosis can actually be reversed. And in fact, we don't have to use a stent all the time. We only use it in cases where it's 70% or greater, because sometimes just doing the right thing, you come back a year later and you look at that same vessel, that blockage would have either regressed or disappeared. So doing the right things is good for your heart. It also prevents new blockages, but can regress what's been done. And that's not just true for stenosis, that's for heart failure. You can improve that ejection fraction, that you can reduce arrhythmias. So a lot of different things.
Great. The next
Stents
question.
do not move, by the way. If they're in there, they become part of the vessel of the wall. They don't move. Difference between angiogram, and I'm looking at these, Pam, so you don't have to.
Perfect, thank you.
So angiogram, an ultrasound is basically what they do for pregnant moms, an ultrasound. The angiogram is that procedure that we take you to the cath lab and insert a tube. So we're having direct access into the heart. The ultrasound is just done externally, and it uses sound waves. Likelihood of having more than one stent, really it all depends on how much blockages you have. If you have a bunch of vessels with a lot of blockages, we can't treat it all with one stent. We have to use different stents. I would say the average that we end up finding is using 1 or 2 stents if we need to. Why are women's symptoms? That's a very good question. I don't think people understand why women's symptoms are different than men's. It may be related to hormones. I don't know, women are complex, what can I say? What was any other questions? Anything else that you saw, Pam? Carotid, so a question about carotid. Carotid ultrasounds is just another ultrasound, but it's looking at the carotid arteries to see if there's blockages there. That is the same kind of blockage you would see in the coronary artery. So except we don't have a way to look at the blockages using an ultrasound of the coronary arteries. But since the carotid artery is much bigger and much closer to the surface, we can see it more clearly there. That carotid blockage can, of course, lead to strokes if you have that. So we also screen for that as well here.
Great. Yeah, I think that's it. And someone did ask if you can call and schedule an appointment to get your ejection fraction checked. And of course, yes, we can have you see Dr. Krishnan first, and then he can order the ultrasound to look at your ejection fraction.
Yeah, I would say at least once in your life, you should at least know that, or at least get that, because it's good to have a baseline. So if anything, God forbid, should happen down the road, you will know that, hey, at this point in time, my ejection fraction was 60%. This was this and this. We had these tests, So that's a very key number. I will always ask my patients, especially if they've been recently hospitalized, do you remember what your ejection fraction was? And it's a shame. A lot of them are either not told or they forget, but I want you guys to really remember that, okay? Well, thank you so much, guys. I really appreciate it. And if you need us, reach out to us.
Okay.
Perfect. Thank you. Thank you so much, everyone. Thank you for joining us.
Thank you all.
Thank you.
Bye-bye.
Bye.